I'd like to thank Dr. Greep and Dr. Landsman, the program committee, for allowing me to speak this morning in this prestigious conference on the visceral and spinal cord protection and thoracoabdominal aneurysm repairs. Just like Dr. Greep, I have to also give thanks to all our contributors over the years in the lab, researchers and clinical surgeons. Without their contributions, I wouldn't be here today discussing our work. The best method to protect the viscera and the spinal cord is of much debate. If I were to question individual surgeons here today how they approach the viscera and the spinal cord during thoracoabdominal aneurysm repair, we would see great variability. Numerous surgeons would argue their preferences based on their excellent clinical outcomes, but rarely do we see in the literature sort of a scientific explanation to support one method over the other. Regardless, clinical outcomes with regard to spinal cord ischemia and visceral complications have continued to improve. The incidence of GI complications during thoracoabdominal aneurysm repair is quite low. In this retrospective study by Dr. Safi's group, the incidence of GI complication was 7%. The two most common complications related to thoracoabdominal repair was mesenteric ischemia and biliary disease, which also had a significant impact on mortality. On 1,100 repairs, over 1,100 repairs, the 30-day mortality associated with GI complication was 40%. They found that biliary disease, which was most commonly was acalculous cholecystitis, hepatic dysfunction, mesenteric ischemia, increased significantly their mortality. And on multivariate analysis, they found that the involvement of the visceral segment during the aortic repair and the patient's preoperative GFR had an impact on developing GI complications. The authors go on to note that they found that atherosclerotic aneurysms were at the highest risk for embolization during the repair. The same group also goes on to describe how the impact of renal failure has on postoperative outcomes. And this particular series, if you developed acute renal failure, there was a 32% mortality. But the important part of this paper was that they looked at the different techniques in perfusing the viscera, either using cold blood perfusion or warm blood perfusion. It appeared that cold blood perfusion had a significant decreased number of patients developing acute renal failure. And cold visceral perfusion did not alter renal protection, although it did have a positive impact on hospital mortality. Dr. Caselli and his group looked at this at two different types of perfusion techniques, either cold blood perfusion and cold crystalloid perfusion in a randomized fashion. Now, their targeted goal in their perfusion strategy was to achieve a left kidney temperature of less than 15 degrees Celsius. They were successful in achieving this temperature in only 37% of patients. But regardless, they didn't see a difference in the perfusion techniques in renal outcomes, and they checked biological markers in the urine. They didn't see a difference, and there was no difference in early death in the postoperative period. And they also didn't see a difference in outcomes depending on the degree of hyperthermia. They looked at patients who had temperatures of the left kidney below 15 degrees Celsius, between 15 and 28 degrees Celsius, and they didn't see a difference in renal outcomes. We also reviewed our literature, our experience with thoracoabdominal aneurysms with respect to mild and deep hyperthermia, and this was over a 7-year period, and there was about 262 patients. But we performed a propensity scored matched analysis on 90 patients. And we looked at the effects of either deep or mild hyperthermia on reversible and permanent adverse outcomes. And we looked at the effect of distal ischemia time, and distal ischemia time was calculated as the time for circulatory arrest, if used, and the time to reestablish distal perfusion. Our initial analysis showed that if the patient had a previous elephant trunk, that they had a lower incidence of reversible adverse outcomes. On the chart on the bottom, you see how the probability of reversible outcome is influenced with the length of distal ischemia time. In summary, we found that as the distal ischemia time increased, there was a significant lower rate of reversible adverse outcomes with deep hyperthermia. Deep hyperthermia and a stage 2 elephant trunk on logistical regression analysis showed a statistically significant decrease in the odds of developing a reversible adverse outcome. When we compared our deep hyperthermic patients with those patients who had mild hyperthermia without a previous elephant trunk, there's also significant differences, both in the renal failure rates and the liver failure rates, which favored the deep hyperthermic patients. There was a trend towards improvement in lower numbers of hemodialysis in the patients with deep hyperthermia. And overall, the percentage of patients with any reversible outcome was higher in the mild hyperthermic group. As we look across the literature, we see more and more individuals using deep hyperthermia as a protective strategy for organ protection in thoracoabdominal aneurysm repair. Although our colleagues in Texas, Dr. Safi and Caselli, continue to use mild hyperthermia with cold perfusion of the viscera, achieving excellent results. To summarize, the literature supports the use of cold visceral perfusion. Cold blood may not be better than cold crystalloid, as we've seen in the paper I presented. The targeted visceral temperature remains debatable, although it appears it should be less than 28 degrees, and some would argue even lower than that. Deep hyperthermia appears to protect the organs quite well, as seen in our paper. And if you have extensive aneurysm, a stage procedure seems to lower the incidence of reversible adverse outcomes. Now, moving on to spinal cord protection, this is also another area of debate amongst aortic surgeons and how we look at the vascular anatomy of the spinal cord, the need for neurological monitoring in the operating room, the use of adjuncts in and out of the operating room, and how do we protect the spinal cord with endovascular repairs. Dr. Crawford clearly described the risk of paraplegia with the extent of aortic replacement in thoracoabdominal aneurysm operations. Most aortic centers today have at least halved the risk of spinal cord ischemia with contemporary approaches. As you know, our group has had an enormous interest in looking at the anatomy, physiology, and the injury patterns of the spinal cord during thoracoabdominal aneurysm repairs. Now, Dr. Griep touched upon this yesterday, so I'm not going to spend too much time, but how hypothermia increases the ischemic tolerance of the spinal cord. We also looked over the course of our studies at the influence of these extra anatomical, extra segmental blood vessels on maintaining the perfusion and the integrity of the spinal cord. In this particular study, we used MEPs as a signal of, or as a sign of spinal cord ischemia. When the hypogastrics and the subclavian arteries were maintained open, we were able to take 13 pairs of spinal arteries before seeing a loss in MEPs. As you see, as we clamped the segmental arteries, all the hypergastric arteries in our pigs, we were only able to sacrifice a lower number of segmental arteries before we saw a loss in MEPs. And this was one of the first sort of glance of what the collateral network was later going to tell us. This particular study, we looked at the perfusion pressure of this collateral network, and we placed this arterial line in the cut end of one of the segmental arteries, in this case, in the L1 segmental artery. The spinal cord perfusion pressure is about 25% lower than the mean arterial pressure. But as you sacrifice the individual segmental artery, you see a dramatic drop in the spinal cord perfusion pressure once you sacrifice all the segmental arteries. And that drop in pressure continues 5 hours after the operation or the last segmental artery is sacrificed. And we should note that the perfusion pressure does not increase until 24 hours or start to increase until 24 hours after the operation, and also does not return to baseline until 5 days after the operation. In our pig model, when you sacrifice all the segmental arteries, about 60%, give or take, of the pigs will become paraplegic. We've also done this study in our surgical patients where we placed a catheter inside of the segmental artery in the middle of our resection. Here you see two perfusion techniques, one on the left using a circulatory arrest, on the right using distal aortic perfusion. And the black bar represents the spinal cord perfusion pressure. And you see, as we sacrifice the segmental arteries prior to going on bypass, you see a dramatic drop in the pressure. And you see a further drop as we initiate non-pulsatile cardiopulmonary bypass. You only see a rise in the spinal cord perfusion pressure once we come off bypass and have pulsatile flow. About 5 of these patients, we left the spinal catheter in place in the postoperative period for 24 hours. And we documented all the hemodynamic variables in this 5 patients: the mean arterial pressure, the CSF pressure, the CVP, and then we calculated what we call the corrected spinal cord perfusion pressure. It was one of the patients developed evidence of spinal cord ischemia. What we found was that there was a significant higher level of significant higher CVP in the patient who had paraparesis. And when we calculated the corrected spinal cord perfusion pressure in that particular patient, it was significantly lower than the remaining 4 individuals. Now, we've also looked at this perfusion pressure when we tackle the segmental arteries in a staged fashion. As you can see, the dotted line shows what I showed in the prior graphs, the dramatic drop in the spinal cord perfusion pressure with sacrifice of all the segmental arteries in one setting. But you see less of a dramatic drop in the spinal cord perfusion pressure when you take this in a staged fashion, either the thoracic first or the lumbar first. The drop in perfusion pressure is quite less dramatic. In this particular study, when we staged our sacrifice of our segmental arteries, we achieved excellent neurological outcomes. As you can see, in the staged group, we had 100% recovery of our pig's limb function. We've also looked at our clinical experience and saw that as we take all the segmental arteries or have an extensive aneurysm resection, we had some injuries to the spinal cord. But if we take it when we sacrificed segmental arteries in a staged fashion, now not deliberate in this case, we had better neurological outcomes. Now, as we get a better understanding of this collateral network, you can see that patients who have extensive aneurysm, we start to tackle them in clinical practice with a staged approach. Here you see a patient who had distal aortic arch plus a type 2 thoracoabdominal. Patient undergoes sort of a Spiegel arch replacement followed by a type 4 replacement. And then approximately 1 month later, we finished the repair with an endovascular repair, and this particular patient had excellent neurologic recovery. Now, we had anatomical, we had physiological, we've also had blood flow studies, which are not shown here today. But what does this collateral network look like? And what we did was we perfused these pigs with a low resin acrylic, and to our surprise, we found an enormous and elaborate network of blood vessels within the intrathecal space, communicating with the extrathecal space. As you can see, an elaborate vascular network, even within the substrate of the spinal cord, communicating with the paraspinal muscles, and in itself has a rich vascular network. And you can see we've come a long way since our anatomy textbook, which we all studied as a first-year medical student, how we've now gained a better understanding of the vascular anatomy of the spinal cord. And these are just additional pictures of this elaborate network. And if Dr. Grieb could rewrite letters, this would be the picture that he would put in our anatomy books on the vascular network around the spinal cord. So in general, in summary, mild hyperthermia increases the ischemic tolerance of the spinal cord. And if you look at the literature today, some would even argue that deep hyperthermia even protects the spinal cord in a greater fashion. The subclavian and hypogastrics, and we've shown that the hypogastrics are even more important inputs to the to the collateral network. We also need to remember that in the postoperative period, that 5-hour period is a very vulnerable time for the spinal cord, especially even up to 24 hours, where the spinal cord perfusion pressure starts to rise, and it does not get back to baseline until 5 days later. It appears by both clinical studies and also our laboratory studies that we have better functional outcomes if you're able to stage your procedures. And the collateral network appears to be a very elaborate network, which does not appear to be dependent on one or a series of segmental arteries. So future studies, now that we have a better understanding of this collateral network, how does this stage repair work, or how does it influence the spinal cord? Is there angiogenesis? Is there vascular remodeling? How can we manipulate this collateral network? And we're toying with various ideas right now in the lab. With the goal basically is to provide total aortic replacement, sort of type 2 replacement, either endovascularly, to achieve the best neurologic outcomes. Thank you.